Good afternoon, everybody. Thank you so much for joining us today as we are taking a step back and looking at back to the basics with traditional MIPS. If you are expecting an in-depth look at each of the categories and advice on how to do things for specific, this might not be the webinar for you. But today, we're going to take a look at what everything means, when it started, give you some tips and tricks, as well as what you can get started and do today. So just said, I'm Mike Lewis. I hope that you have participated in our webinars in the past. If not, and there are other topics or you need a more advanced topic, there are in the top part of our screen at healthbonics.com. You can see all of the webinars that we have done in the past. A couple things that we are going to review today. The MIPS highlights, the 2023 final rule highlights, program changes. So what has changed in the year as you're getting ready to get started, and what you need to do now to improve your MIPS scoring. A little bit of background here. If you go onto the GoToWebinar widget on the right-hand side, you will see two areas that I want to bring to your attention. One is the question section, where you can ask questions to me. If I have time at the end of this call, I will get to the questions. Otherwise, I'm usually pretty good at getting back to everybody after the webinar is complete. The other area is the handout section. In the handout section, you'll not only see the slides for today's presentation, but you will also see the some information in regards to MIPS in 2023 and about our product MIPS Pro. So, as I stated, this is a back to the basics. This is basic MIPS, meant for those maybe new, need to understand a little bit more, refresher for others, but we do have other webinars that we've done that go into more detail than today's call. But it is a very long webinar. I expect this to take about 45 minutes. So bear with me, and I'm hoping I'm able to answer a lot of your questions. So why was MIPS developed? MIPS was designed to tie payments to quality and cost-efficient care, drive improvement in care processes and health outcomes, increase the use of healthcare information, and reduce the cost of care. So how was MIPS created? Medicare's legacy quality reporting, if you all remember, back in the day, there was PQRI and PQRS, value-based modifier, and some other programs that were out there, e-prescribing and so forth. But MIPS was created from all of those programs being consolidated into one streamlined function. I worked back then in the quality area as well, and the difficulties of moving towards MIPS in the beginning were hard as it was moving. The biggest change was moving from just Medicare patients to all payers. That was the big lift. And then since then, the biggest lift has been the harshening of the scoring methodologies, as well as the minimum scores to reduce the penalties. Give me 1 second. All right. So MACRA created the quality payment program that repealed the sustainable growth rate formula, added quality and cost of care into the healthcare for Medicare patients. The changes rewarding clinicians for quality over quantity. Their goal is to, get the patients better rather than seeing more patients. It streamlined all of the things that I talked about earlier, all those different programs. And the idea was to give bonus payments for participation. In the beginning of the program, those were done with cash payments, and now it is being done by a percentage on your metrics in the previous year. So it take 2 years, sorry, 2 years back, which we'll get into as well. So CMS had a couple of objectives, things that they shared with us through their final rule, as well as during some of our calls with CMS as a qualified registry. What they really want to get out of MIPS in 2023, promoting more meaningful participation for clinicians. That has a lot to do with pushing people towards joining ACOs, making them more attractive for specialty providers, as well as those in primary care and hospital settings. Providing clinicians a continuity and consistency, gaining familiarity with MVPs. So in 2023, there's a new platform for reporting called MVPs. It allows providers to be more in line with what they are as a specialty, as well as limiting the number of measures and cost measures that they need to do. If you want more information on MVPs, I did a webinar a couple of weeks ago on MVPs, as well as I have a couple blogs out there on our website. Once again, if you go to healthmonics.com, you can see that information in the top right-hand corner for the webinars and blogs. It'll tell you a little bit more about MVPs. And if you have questions, if your group is eligible or wants to report an MVP and you have some questions, please feel free to reach out to me. Reducing the burden and facilitate participation in APMs, I mentioned that. Further advance health equity and expand coverage. One thing that was in this year's final rule that I hadn't seen as much before was the push for health equity. Over 700 times, I think the word equity was in the final rule, and they really are trying to push the laws and regulations of not only the advanced payment models and MVPs, but into MIPS and that type of care to facilitate better care for those that are in disadvantaged locations or have other disadvantages compared to the population. So now to get into more detail with some of this. The first one, quality data completeness, staying at 70% of all eligible patients for each measure. That is the same. That is very important to understand a couple things from a basic standpoint. This is not just Medicare patients when you talk about registry reporting or EHR reporting. It needs to be all eligible instances are counted. So if you have 5,000 patients in your denominator for patients that are eligible for the medication list, you need to have 70% of those visits included in your denominator when you go to report. So we need to make sure that that is per measure and it includes all patients are the important parts of that. The minimum threshold to avoid the penalty this year is 75% or 75 points. You can take a look at what that looks like from breaking down. We're going to get into a couple screens that show you how you get each of these points so that you can do better. So how is it broken down? This is for a large practice or a small practice that decides they want to report PI. The breakup is quality is 30%, cost is 30%. Your promoting interoperability is 25%, and improvement activities is 15%. The eligibility requirements are still the same. You need to have all of the above to be automatically eligible. That's 90,000 in Medicare Part B allowable charges, 200 plus Medicare Part B patients, as well as 200 plus covered professionals. If you have at least one of those three, you can be what's called an opt-in provider or an opt-in group as long as you have one of those three. If you do not meet any one of those three, you're not eligible to report, and you can use a system like ours and report to CMS, but it won't count for anything besides that you tracked it for the year. The biggest change, I think, for 2023 reporting that came about is that there's no more payment adjustments for exceptional performance. So the 2022 performance year, 2024 payment year was the final year for the additional performance threshold. Basically, that $500 million that was added on top of the MIPS incentives, it disappears. If you ask me, that's what's paid. The increases over the previous couple of years during COVID because of all of the people that took the EUC or were taking exemptions, that in 2023, with those exemptions mostly going away, you're looking at this incentive is going to increase because there will be more providers and more groups that are in the penalty in 2023. So I think it's going to more than make up for the exceptional performance disappearing, but not guaranteeing anything with that. The penalty threshold, how does that impact you over time? Achieving MIPS incentives will continue to be more difficult. There is no easy way out. I think that's been quite evident in the last year. 75 points to get to. There's no easy cheat method like I've shared with you in the past during these back to the basics. This year, you really need to do well in these measures to score well and avoid the penalty. There will be a lot of providers that performed well in previous years that will not perform well this year because due to the changes. And paying attention now, starting in March and April, instead of waiting to just report your data at the end of the year, is imperative. So this actually, I believe, is a lot to do with a question that just came over, but with the eligibility, to be eligible for reporting MIPS, you need to be identified as a MIPS eligible clinician type on Part B claims. So you can check that out on our site. We have a eligibility tool, or you can check that out on the CMS site that I share with you, whether you are eligible for MIPS or not. You've enrolled in Medicare before 2023, so anybody that is new to Medicare in 2023 is not eligible for report. You are not qualified to be an qualifying alternative payment model participant, and that you exceed the low volume threshold as an individual. So one of the three categories that we went over before, you need to be have one of those to be eligible. So the MIPS payment adjustment factors, very similar into previous years. The one thing that you will see is that it is a straight line from negative 20%, from 20 points straight up to 100, with little discrepancy between the changes. Between all of that is one straight line. If you have less than, I think it's 18.5 points, you will get penalized the full 9%, and then it scales up from then. So if you score a 66, you're not going to receive the full 9%, but you'll get closer to a 2% penalty. And then you can see what it looks like up at the top. And these obviously can be adjusted or will be adjusted based on scores that come through, how many people report, and whether there is any other type of exemption status like there has been in the last couple of years. So taking a look at the scoring policies from a graphical standpoint before, now we'll take a look at it here. What you can see as from 0 to 18.75, you'll get a negative 9% adjustment. Then from 18.76 to 74.99, you will get somewhere between that 9% and 0%. What you can see on the right-hand side, the 2025 MIPS payment year is the 2023 reporting year. So everything is done 2 years after. So in 2023, you will collect the data and report it in the beginning of 2024. And then halfway through the year, they'll tell you what your score is. And then come January 1st, 2025, the adjustment will be made on your Medicare payments. A score of 75 will get you a 0 adjustment, so there'll be no change. And then from 75 all the way up to 100, you will go from a range from 0 to 9%. That range has been very different over the years, as high as around 4% and as low as about 1.5%, based on the number of people that are being penalized in the program and so. So let's take a look at 2023 reweighting for a small practice, and then we'll take a look at it from a large practice ability. So a small practice are provider groups that have 15 or less providers in their group. And those groups, if they are to be reporting all three categories that are eligible, quality, cost, and IA, they'll be split up as you see here, 40%, 30%, and 30%. They are, so PI is automatically reweighted within a small group. However, you can still report the PI category, and I will show you why you would want to do that, or maybe want to do that on a following screen. When both cost and promoting interoperability are negated for the year for 2023, each, the quality and IA, will be 50% of your score. And if you've been participating in MIPS, the IA is points that you do not want to miss out on. You want to make sure that you get those points. They're easy points. They only are 90 days. Most practices are doing some of the things that are in there. Take a look at it now. Do it in the summer rather than waiting to the last 90 days of the year, and so forth. For a large practice, the way the reweighting works is a bit different. So if they are PI exempt, the quality score is 55%, cost is 30, and IA is 15. So that what you're looking at here basically are those that are the PI exempt people are non-patient facing, as well as some other category types that are PI exempt in here. Therapists, PTOT, psychology, and so forth are exempt from PI. That's how theirs will be reweighted. If they are PI and cost exempt, you're looking at 85 points for quality and 15 for IA. So a very big difference there. Those freebie points of IA are much larger for smaller groups than they are for large practices. So now we're going to dig into each of the categories a little bit and to give you a general overview of what it is. So the quality performance category requirements for MIPS, for that you need to report at least 6 quality measures, and at least one must be an outcome or high priority measures from the 200 plus available MIPS measures that are out there. Whether those are CQM, which are registry measures, ECQM, which are EHR measures, which here at HealthMonix we're able to report on as well, or they are the various QCDR measures that are out there. CMS does have them listed on their webpage. So when it comes to the traditional MIPS and the quality measure overview, you can see that the big thing is there are a number of measures finalized with substantive changes. I don't like the word that they use, substantive, because it isn't most of the time. It's a code or a couple codes, maybe a denominator exception or something like that. But there are changes and a lot of common measures as well. There aren't a bunch of new measures for the year. There are 8 in the CQM area, 1 in the ECQM, as well as 1 administrative. The +9 that you see at the bottom is cumulative, so the ECQM is probably, or is a CQM as well, so that there's only a total of 9 measures that are new. There are a number of measures that are no longer around and have been removed for 2023 reporting from traditional MIPS, and you'll see what some of them are, because there are some notable ones as we move along. So the new quality measures here, what you can see, there are measures across many different domains, from kidney to psoriasis to things I can't even say. Risk standardized acute cardiovascular related hospital admission rates. So there are a lot of new measures. The one that I do want to point out is 493, which is going to be the adult immunization status, and we'll share with you in a minute. That is going to be a very popular measure, as well as measure number 487, which is a screening of social drivers of health. As I stated before, CMS is really pushing for the ability for us to have health equity in the country for the Medicare patients and for everybody else. And therefore, that's going to be an important measure moving forward. So when it comes to new measures, and why I say it's very important to understand these, is that first year measures have a minimum of 7 points eligible. No matter how well you perform on that measure, you will get a minimum of 7 points. The other question here is that second year measure is that minimum of 5 points. So if there's measures that are in their second year of reporting, which you can see right on our website, you will get a minimum of 5 points. The reason why I say these are important is because a lot of these measures, the ones that have been around for a long time, your current medication list, your advanced care planning, your diabetes, and all the more popular measures are really hard to do well in. So when you're not doing, when you don't know if you're doing well in a measure, having a measure as backup that you get a minimum of 7 points for can be a pretty important measure to have. The other thing here is that you're not guaranteed only 7 points. If you do perform well, you can get up to 10 points if benchmarks can be created. So minimum of 7 points for first year measure, great as a backup. Need to have at least one in the numerator for each one of those measures, but your performance is not mandatory. There's no actual performance standard to get you that minimum of 7 points. Here are the list of the removed quality measures. A couple of them are ones that I recognize as things that have been used a lot. Measure 76, 265, and 375 are ones that are very popular within reporting. So this is right on the list for the handouts. If you want, you could take a look at those. But I think the really important one that I want to hit on is that measures 110 and 111 are gone from traditional MIPS. Very important to understand that. I would say more than 50% of the people that report MIPS are reporting or have reported on these two measures in the past. So they are gone. They are being added to another measure that I shared earlier that is also going to include your zoster vaccination as well as your Tdap, and have both of those with the pneumonia and the flu. It is a lot of reporting, a lot of more reporting for these measures. Someone's asked for me to go back to the removed quality measures, so I will go back here for a second so that they could grab a screenshot of what that looks like. But once again, really important to understand that measure 110 has the 110 and 111 are no longer going to be available in traditional MIPS. There is an MVP that has both of those measures in it, but not, once again, not available. I can't say it enough in traditional MIPS this year. So if you've been tracking those measures for a long time, you're going to want to track new measures this year. Quality measures with changes. As you can see, the list is long, as well as you can see that there's a lot of very popular ones. I highlighted the red ones here, not because there's anything special, but because those are amongst the top 15, 20 measures that we report here at Healthmonics on a regular basis. There's the diabetes, depression screening, breast and colorectal screenings are in there, as well as medication, smoking, and so forth. So you'll see a lot of measures that have been very popular and been around for a long time that have some changes this year that you want to be wary of. Quality performance category scoring, the removal of the 3-point floor for quality measures. For the traditional MIPS, there won't be a 3-point floor available under MVPs. Small practices will still continue to get that 3-point floor for each of those measures this year. Measures without a benchmark or that do not meet case minimum will earn 0 points. That also includes outcome-based administrative claim measures that if they were selected for an MVP. I don't want to get too far into MVPs, But there are some unique rules and laws around the MVPs if you're interested in doing them and learning more. Once again, I do have that webinar out from a couple of weeks ago. So moving on from quality, I'm going to move a little into the cost category. So for the cost category, and what it really is it's designed to evaluate the cost of care for Medicare patients. CMS determines the highest spend categories. Measures were intended to make providers aware of costs, and they're adjusted based upon patient risk. So they're not saying don't see sick patients. They're saying that when you see sick patients, to perform the steps to reduce costs and improve quality. Rewards are eligible clinicians for cost-effective care. CMS uses Medicare claims data, so it's not data that is tracked in your EHR. It includes data from a lot of times, especially when you're talking about the total per capita cost measure. It includes a lot of visits to other types of providers and other providers that may have seen that patient. So it's information that you necessarily won't have. And there is no submission requirement for it, as well as clinicians are benchmarks against other eligible clinicians. So just to ask this question, what makes you cost exempt? Right there to the next page. So if you're cost eligible, that's really the only thing. You're not really ever exempt from cost. You can be not eligible for cost, so not eligible for any of these individual measures. So currently with these measures, there's the TPCC, which is the total per capita care. You need to have 20 patients that are not attributed to you. MSPB, or that are attributed to you for you to receive to be part of that measure. MSPB, which is the Medicare spending per beneficiary, you need to have at least 35 episodes to be eligible, and this is on the group level, by the way, just want to make sure. And then there's the other episode-based measures that it's 10 or 20 eligible instances. So there are provider types that are not eligible for the TPCC section. We do have lists of those as well, but the other measures, the episode measures, as well as MSPB, it's not necessarily that you would be exempt. It's that you would be not eligible for those types of episodes of care. And each one of those are laid out right on our website with what type provider types would be in there. The one thing that you want to make sure that's not really covered a lot is for TPCC. If you have extenders, PAs and NPs, they are included in those measures. So there are 25 total cost measures. CMS is intent to cover all providers in the future. So right now there are a limited number of specialties that are included. But as we move forward and as this program grows, CMS would like to have cost members associated with each type of provider that is billing Medicare. The attribution is based on the provider specialty and services. So episodes are triggered based on services that are billed. And you can see for each one of the different cost measures, there are different episode triggers. And the data includes for the cost of that patient, pre-trigger events and post-trigger events. So they can go throughout an entire year. They could be a short period of time. They could go through multiple years. And then additional services assigned to episode based on trigger event. Risk adjustment is based on patient risk factors and other factors. A question that came across is, does a higher patient risk score equal a higher cost? No, that's not necessary. A higher risk score reduces the cost. It's actually opposite. According to CMS, remember, cost and revenue are different. So while you may gain more revenue from a patient, if they are a higher risk patient, it is counted as less. Risk adjustments based on patient risk factors, measure average of all episodes. So no matter if it's the big TPCC or MSPB or one of the episode measures, they're going to add all of these measures up together and provide you an overall score. So you could have 20 patients with one of the episode measures. It counts the same as 5,000 patients for the TPCC. Before I move into promoting interoperability, there were two cost questions I thought I'd get answered here. How many cost measures do you need for CMS to count the cost category? You actually don't, you need one. So as long as you have one cost measure, they will count the cost category for you. And then is there a list of specialties that track for 2023? On our website, you'll see what CMS says are the not recommended, but who the normal specialty types would be in there. But I would look at the cost measure and to see if you have those visit types, there is a good chance that you will be cost eligible for them in the future. And you could call one of the people on our sales team here at Healthmonics and they could kind of guide you to what that looks like as well. So as we move on from the cost category, I'll say it once again, I probably said this a couple times, we do have many different types of webinars available, and the cost ones are very good, and we will be putting out new cost webinars in the near future so that everybody can understand those, and those go way more in depth than just 3 or 4 slides. So know what categories you need to report. Do you need to report promoting interoperability? Small practices with 15 or fewer will automatically be exempt, so there's no exemption that you need to take anymore for those. Clinicians such as nurse practitioners, therapists, psychologists, non-patient facing providers are automatically exempt as well. Just know that when you're talking about group reporting, if they are part of a group and you're group reporting for those providers and a majority of those providers are not PI exempt, then you will have to report PI for those providers. There are also some providers that can apply for exemptions as well, the EUC or the extreme and uncontrollable circumstances, as well as if your EHR has been discertified. So what would be the reason of you breaking this down? A couple of questions actually just came in on this. So why should you or shouldn't you report PI? The big understanding here is if you have a better percentage in PI than you do in quality, you want to add PI and report the PI for the 90 days because it will bring up your score. If you have a lower score in PI on any 90-day period, then your quality score, you want to leave it out. So the breakdown for MIPS, if you include PI, is what you see on the right-hand side is our normal weighting. Without PI, you can see for small groups what it looks like here. And this isn't small groups. Yes, it's small groups, what your PI is going to look like. I actually think these numbers are off, and I will change them before sending everything out. So scoring methodology for performance period, I'm not going to go into each one of these, but they are very similar. There has not been a ton of changes, a couple small ones that are there that I will go over in a minute, but there is not a bunch of changes from year to year of what needs to be reported for promoting interoperability. There is a new required measure, query of prescription drug monitoring. It was previously optional. It's being expanded to include Schedule 2 and Schedule 3 prescriptions, and that in 2021, the American Medical Association report found that physicians use state-run PMs more than 910 million times. So it's something that is being used constantly out there. The exclusions for it are you are unable to electronically prescribe Schedule 2, Schedule 3, and Schedule 4 drugs under applicable state laws. You write fewer than 100 permissible prescriptions during the 90-day period, and any MIPS eligible clinician whom querying PDMP would impose an excessive workflow or cost burden. So that's just for 2023. It kind of gives you the out for this year as we're moving along. There is discontinued reweighting for the following clinician types. Promoting interoperability no longer will be reweighted for nurse practitioners, physician assistants, registered nurse anesthesists, and clinical nurse specialists. So those are the categories now. Anesthetists, I got it right though. I had to look at it twice here for the year. However, they are continuing the reweighting policies for social workers, therapists, speech pathologists, audiologists, as well as clinical psychologists, registered dietitians, and other nutritional professionals. Improvement activities. So for improvement activities, you need to attest to 1 high-weighted or 2 medium-weighted improvement activities from a list of 200 plus improvement activities. Those are really everything for those measures. There's not much more to go in. They're the same as last year. There was a couple missing, and only I think 1 or 2 new ones for 2023 reporting. But it is still the same obligations that you've had in the past with no changes for improvement activities. So how are you going to avoid the penalty this year? I'll go over large practices first this time, and then I'll get into smaller practices. For the large practices, what you'll see when there's no exemptions, you really are going to shoot for a perfect score in IA. I give you an example of what it looks like for cost if you're at 50% for cost, but obviously that is a number that can be very different for your organization. And then when you take a look at PI and IA, you want to get a good 80 to 90% of your scoring from both categories. When you take cost out, the numbers are very similar. You could do a little less when it comes to quality reporting, but still performing very well in that category. The basic thing is that you do need to perform very well. Oh, this is wrong too. I'm sorry. For this one here, for large practices, this one here should be 15, and this one up here should be 60. I will change both of those. But once again, as a large group, you're going to need to have a good majority of your points coming from the quality category, as well as scoring almost perfect in IA and PI. And that really is to combat cost, which is going to be variable based upon your practice. When it comes to small practices, if you were going to not have PI or cost, you can see that you could actually do not that great in quality and still get penalty avoidance. It's a real benefit of a small practice, 15 or fewer providers have, where you can do 50% on your quality side, get the full score for IA, and still do very well. No PI, so this includes the cost category. What you can see is that you once again have to do perfect in IA. You could do semi-well, 75% on your quality, and then showing it just a 50% for cost. And then same thing with if you decide to include PI, what you need to do. Once again, for you to do PI, you should be outscoring what you're doing in quality for you to want to report that this year. Couple questions real quick. PI question was, is PI now optional for small practices? PI is exempt for small practices, but you can opt in. So I guess optional is how you would take that. And for the cost category, there is no exclusion for cost category based on size of your practice. You can take a look at the exemptions that may be available to you, but the cost category is coming and is here for small and large practices the same. So something that I share in each one of my calls, reporting as a group and individual at the same time is important for you to maximize your scores for each provider. There may be providers within your group that can score better than the average for the TIN. And for those providers, you'll see that they can benefit from reporting both. So for an individual, if you were to report individual providers only in your group, each provider gets their own score. Some will be below the average of 89, some will be above the average of 89. Hard to meet the 20 patient minimum for some of the measures, so group reporting allows you to get to those minimums a little bit better. As well as you can't take advantage of patients seeing multiple providers for the most part. Group scoring, everyone gets the group score. Gets pulled down by lower scores, but allows you to take advantage of all the other patient minimums and patients seeing multiple providers. The big issue here is that you're going to have problems with those providers that are keeping your scores down and not holding up their own weight. If you report both, that's what you get in the best of both worlds. Those providers that score better than 89 will get their individual score. Providers that have less than 89 will get the group score. There is no disadvantage. They do not take any points out of the group score by pulling out individual providers. Their data is still included in group reporting, but CMS will give you the highest of the two scores. And then if there are other things like MVPs and groups like that, then CMS once again will take the highest of any of your scores eligible in 2023, unless you're part of a virtual group. And we can talk about virtual groups offline because that brings in a whole different area of confusion. So what can you do, and what do you need to do to maximize your performance? So for traditional MIPS, getting started at the beginning of the year. I know we're in March. We're at the end of March. The month ends at this weekend. And we're getting into April, hopefully some warmer, sunnier days in April as we're moving along. Start tracking your MIPS category earlier in the year. Complete your 90 days for PI and IA. Get them out of the way. Yeah, you can improve on your PI score throughout the year and so forth. But right now, you want to make sure you have at least a decent score for those measures. And then utilize program like MIPS Pro that can provide quality measure benchmarks early in the year. We start tracking our measures January 1st. So you can, if you signed up right now, you could upload your data into our system and start tracking your performance. Focus on performance improvement activities, looking at your gaps in care, understanding your EHR ensures appropriate data that's collected, right? Are the codes coming across? Are you able to see that if a doctor clicks on X, Y, or Z, that it's counting for you for those measures? Determine those providers or patient groups or measures where you're not doing well. You can start tracking that today. Better make changes now in April and May than it is to try to figure out how to make changes retroactively in January of next year. Track more than 6 quality measures. I am a big proponent of this, more than I have been in the past. Before there were some bonus opportunities for it, but now the reason that I tell people to do that is because CMS tends to change the rules often in the middle of the year. They take away measures, they change the way measures are done, they take some time frames away from measures. But the other thing is that the scoring can, not be what you expected. And if you have 8 measures and a couple of them being new measures, you give yourself an opportunity to make up for missing and for mistakes that you've had in the past. So when choosing measures, there's a couple of areas that I highly recommend. Select measures that fit into your specialty and workflow. Less confusion for patients that aren't being asked measures that have nothing to do with your specialty when they come in for a visit, and tend to interact with your staff in different ways if they're being asked questions outside of the realm of care. Determine measures that have smaller denominators. So I am a big proponent of finding measures that you can do that, let's say, are 30 over 30, or you have 30 eligible instances and you got them all right. And if not, you can, that's more points. It's worth more for most cases than having 5,000 over 5,001 for some of the tougher measures that are there. So find out measures with smaller denominators. Identify measures that are not topped out. So there are lists of topped out measures. They're on our webpage as well. That are not topped out. That way you give yourself an opportunity to choose measures that you can get full 10 points for. Examine measures that you can report through an ECQM, which you can do through our system. There are better benchmarks for the most part, not for all parts, but for the most part for ECQM measures. And then find new measures, as I stated before, that are going to get you those 5 to 7 points. So when I talk about the measures with the smaller denominators, here's basic example. You have these broad measures like the smoking and alcohol measures, the medications that have very large denominators, right? They are ones that may not have a CPT ICD-10 code combination that is opts people in. So for measure documentation of current medications, that's every visit measure. It's all patients 18 and over, and that there's no diagnosis included in it. So that's going to be a very large group of patients, right, to do. Otherwise, if you take a look at something like measure 39, and not saying this is great for everybody or that this measure is even, a great measure to report, but screening for osteoporosis limits it to females, right? So you're cutting your population hopefully somewhere close to half, 65 to 85 years old, as well as it's once per performance period, and that the diagnosis for osteoporosis in the data encounter is not there. So it's limiting your patients pretty drastically for this measure. And there's lots of measures that are out there like that. They are the more specialty specific measures that are there. But I highly recommend taking a look at those because you could have a couple changes in the year and perform well on these measures. It is harder to change an entire structure of how you report with some of the bigger large denominators. Lord. Look for measures that are not topped out. So little background explanation of what topped out measures are. There are two different types of topped out measures. You have topped out measures at 10 points, basically meaning that you need to have 100% to get the full 10 points. Otherwise, the numbers drop drastically from there. Capped at 7 points is another option so that the most amount of points you get is 7 for those measures. Those are median performance scores 95% or higher. So these are the ones that everybody's doing very well with. Performance so high and unvarying that meaningful distinctions and improvement in performance can no longer be made. If everybody's scoring a 95 or higher on a test in school, they're going to change the test so that there is a better curve. And that's the same thing with these measures. Why would they test something and ask something when everybody's already doing it? After 3 years of being topped out, a measure may be removed in the 4th year. For measures that are extremely topped out in the 98th to the 100th percentile, CMS can remove the measures prior to the 4th year. Some of the popular topped out measures are the 128 BMI screening. You need a perfect score for that one. Depression screening, you need a perfect score for that one. Falls plan of care, 155 is capped at 7, as well as rheumatoid arthritis and the tobacco use. For adolescents are all capped at 7 points. So that's the maximum amount of points that you can receive for those measures. Take steps to maximize your return on investment, maximize what you can get out of your quality measures. Choosing the right measures is important. Have an internal meeting with your staff to discuss the importance of MIPS in 2023. I think that there has been some time where it really hasn't been top priority for any organization. However, moving into 2023, there is a significant revenue that will be attached to this, as well as some of the new patient care outcomes here. So you want to make sure that everybody is on board, everybody from your front desk all the way through to the receptionists, or to the PAs, NPs, MAs, as well as people that are calling and doing follow-up on the phone, are all going to need to understand the importance of MIPS. Getting the right tools in place, whether you have an EHR that does a great job with this, you need another submitting platform like a registry, you need to include your billing company and consultants, understand what you could do through telehealth. It's really important to do all of that right now. So a couple things about our product. MIPS Pro offers live dashboards and drill down capabilities. It's going to help you identify gaps in care, performance improvement, as well as score optimization and outlier detection. So you see here, this is just an example of what one of our dashboards looks like within our program. Our easy to navigate dashboard is designed strategically for administrators to track and drive performance improvement, as well as leading to better scores, higher reimbursements, and improved patient outcomes, which is the ultimate goal of our organizations and many of yours. How MIPS Pro helps you report. Not only do we have our MIPS product, we also have a cost product that helps you navigate the cost realm, as well as a gaps in care analysis reporting structure, which you were able to see a minute ago, risk score management, and some other areas. We have best in class US-based support team. So everybody's located right here in Malvern, Pennsylvania, and they're here to help you reduce the burden of quality reporting and allowing you to provide the highest quality care. So I'm going to skim through these next couple slides on costs. I do ask if you're interested in our cost product that you go over and check out our cost webinars that we've done in the past, or reach out to me and I can set up a time to individually go over it with you with someone on my team. So how can you track costs? We have the only platform out there. The main things is that we show the estimated MIPS cost score throughout the year, provide actionable insights into the cost measures, identify your anticipated attribution, as well as score, and sharing individual patient HCC scores, and allows you to easily identify those patients and providers that are impacting your cost score. Here are a couple of screens that I can share with you. Here, what you see are the measures that are calculated for the cost score, what the number of eligible instances are, how much it's costing, and whether it's counted in your score for the year. As you can see, these three scores would be added up and divided by 30, and that will give you your, or divided by 3, sorry, and that will give you your overall decile score. Here's another example here of what you can look forward to by seeing in here is our MSPB. This is by provider. It's a breakdown within your TIN to show you the provider's average per costs for the cost category. And then if you want to even dig further down into the data, what you're seeing here are a little bit more into the analytics, showing your top providers for each one of the categories, as well as what the national average is and comparing it to what you have. We do have more webinars coming up in April. I know we are working on webinars that are going to go a little deeper into the new measures, as well as some of the changes in measures. We will be going over a little bit more about data integration, as well as some other ways to improve your scores, looking at validation and so forth coming up in April. And be prepared that you'll also see some blogs that are coming out on MIPS, as well as the MVPs and other programs. I do not think I have much time for questions, but I will see if I can answer one or two before we head out for the day. Give me 1 second. So there are a number of questions on MVPs as I'm reviewing this, and I'll be honest, I could sit here and answer each one of them. I will get back to most of you over the call. I think it is a little too deep for a lot of people that are on this beginner call today. However, a lot of those were answered during the MVP webinar as well. So if you want, just go over and check out our MVP webinar that we did a couple of weeks back. But the main thing about MVPs is it does eliminate the need for 6 measures. You could report on 4 measures and have 4 measures within a certain MVP, and CMS has set up those MVPs. MVPs are the way MIPS wants to, CMS wants MIPS to go in the future, and we'll be working with that. The small practice bonuses are gone. They were gone in 2022 as well. That's really all the ones I'll have time to get to today. Thank you for participating. I do ask everybody if you could fill out the survey. It really helps me in tracking and what I need to do to better and what needs to go on next. So thank you for your time today. Everybody have a wonderful week and have a good spring. Thank you.